Hi everyone, my name is Rachel Moses and you are listening to the AHP Leader podcast. This podcast is a series of podcasts looking at COVID-19 lessons learned. And this particular podcast brings together a group of healthcare professionals from range from the MDT, particularly talking about some of the challenges and disparities found from those suffering from COVID-19 from ethnic backgrounds and different ethnic backgrounds. And this was particularly in light of the Public Health England disparity reports and the risk of outcomes of people with COVID-19. And the largest disparity seen was in age, but also the risk of dying was higher in those who were male, who were from highly deprived areas, and also from Black, Asian and minority ethnic groups when compared to white ethnic groups. And this didn't just affect patients that we were seeing in our intensive care units and respiratory wards, it also affected the staff that we worked with. And we thought this was a really important discussion to have. So I'm incredibly grateful for the panel for giving up their time and talking about this really sensitive and emotive subject. So I'm going to start by asking everyone to introduce themselves. If I come to Gabby first.
Hi, my name is Gabby Ramlan and I work as a dietitian, and I moved to the UK in 2003. So recently during the COVID period, I was deployed to cover ITU cases because I was training in ITU before. Currently, I'm working as a diabetes renal specialist dietitian.
Thank you so much, Gabby. Warren.
Well, hi everyone, I'm Warren Caffrey. I am currently an MSK physio, and just as the sort of pandemic started, I was a rotational physiotherapist and I was asked to move back to the surgical wards and intensive care unit in my trust, just to support and help manage people at that time. And I'll just go into my background a little bit. So I was born and raised in England. But my heritage is, I'd say I'm dual heritage. I've got a background from being from Barbados and Ireland, Republic of Ireland.
Thank you. Shagan.
Hi everyone, my name is Shagan. I'm an intensive care registrar who works in London. I've been an intensive care registrar forever. And during the COVID pandemic, I was actually redeployed to general practice. I'm just kidding. I was heavily involved in intensive care, doing intensive care stuff. I'm originally from Nigeria. I was born and bred there. I was there till I lived there till I was 14, and then moved over here for A-levels in university, and I've been here ever since. But I still consider myself very much Nigerian.
Thank you. Grace.
Hi, my name's Grace Owusu. I'm currently a diabetes renal specialist nurse. At the time of COVID, I was a diabetes specialist nurse trainee, and then I was redeployed to a COVID-19 ward. My background, I'm originally from Ghana. I was born there, and then I came here when I was 6 months old, so I've been here ever since.
Thank you. Sabia.
Hi, I'm Sobia. I'm a clinical psychologist based at Royal Stoke Hospital on the intensive care unit. So during COVID, I was already working there. In terms of my background, I am born in the UK, but I'm of Pakistani descent from the Kashmiri region, so the Pakistan administered Kashmir. That's me.
Thank you. Kieran.
Hello, I'm Kieran. I am a respiratory physio and I work at Addenbrooke's Hospital. During COVID, we got redeployed onto ITU to help the nursing staff because we ran out of nurses. My background is mixed. I was born in America, grew up here. I don't really have a particular identity other than mixed.
Thank you. Leanne.
Hi, so I'm Leanne Batson. I'm a trainee advanced critical care practitioner. My background is a physiotherapist, and my ethnic background is Anglo-Indian.
Thank you. And last but not least, Zudin.
Hi everyone, I'm Zudin Puthucheary. I'm an intensive care consultant at the Royal London Hospital. I was born in Malaysia. So my mother is Sri Lankan, my father is Malayali. I was born in Malaysia. They sent me to an Anglican school in the United Kingdom. I spent vast tracts of my life in Australia and Singapore. I would call myself mixed. And like my wife is British. I say I would call myself British for no other reason that my children are British. And I think it's really important. So when I sign it as Asian other, because I don't see a category that I fit into.
Thank you. And that's such an important point, Zudin, and it's an important point about terminology as well. And I think that's something that I'm personally very mindful of. And in terms of the terminology we use throughout this podcast may be different from person to person. And Zudin, I'm really glad we're finished with you, because I wanted to bring in some of the additional research you and your team have done around COVID-19 and ethnic disparity findings, particularly within East London hospitals. If you could just touch on that a little bit to help set the scene even more.
So certainly, Rachel. So first thing I'm going to say is that I did not lead any of this work. It was led by a whole group of people who continue to do this work. I'm just part of that team. And in the setting of what we're talking specifically about the research, I guess my role is as much to unpick as it is to offer a cool head when talking about racism. Okay, so we looked at about just under 2,000 admissions with coronavirus to East London across all of Barts Health. Looking at those sort of emergency numbers allowed you to look at all sorts of things and control for all sorts of variables. And essentially, what we found that if you were Black or you were Asian, you were far more likely to die from coronavirus. And your makeup as a person, so a 50-year-old Asian guy in East London has the same sort of phenotype as a 75 to 80-year-old white male. Okay, that was our conclusion. We had a long discussion about BAME, and this is why we went specifically down the Black and the Asian route, because the majority of our Asian population in East London, especially where we are, is Bangladeshi with some Pakistani patients. Now, what you won't see in any of our publications is the vast amount of work done by Barts Health afterwards in some panic to clarify whether or not we were being institutionally racist. And it turns out we're very, very happy that if anything, the reverse is true. We're more likely to admit patients who are Bangladeshi. We're more likely to admit patients who are Black onto emergency wards and onto intensive care. And that has gone through a phenomenal amount of data science. It hasn't been released externally, but I'm very happy to say it will be at some stage. And it's been shown at the ministerial level, from what I understand, because we worry about institutional racism in intensive care. And I'm happy to say, certainly in East London, there is none of that. What we couldn't unpick, and what we're trying to unpick, is the separation between ethnicity and deprivation, because East London is also incredibly deprived. And our indices of multiple deprivation don't necessarily take into multiple generational households. They don't take into work patterns or anything along those lines. So we have not been able to separate out these two yet. And that is the work that Yizzy Wan and John Prowl are going to try and do now. That's the science we've got to so far.
And I think relating that back to healthcare slightly, in the Public Health England disparity report, there was talk about like frontline or more at-risk workers being from Black and Asian ethnic groups. And again, that was a key finding for discussion and for further thought and investigation, wasn't it, Zudin? So I think that the reason why I wanted to highlight that study is because it almost mirrored some of the findings in that report as well.
I mean, it's striking if you look at all the deaths. Because 2 weeks ago, the BMJ had everyone's photos. And it was striking just looking at the pictures, thinking, I mean, it's almost as striking as how everyone ignores it, really. But it is striking to see that actually there's a huge amount of older Pakistani, Bangladeshi gentlemen and Black gentlemen and women. And it's not really that of great interest to the news, but there we go.
So I think that's a great point to now move on to. So I was stood on what was a 28-bedded intensive care unit, and of the 28 patients, the majority were male. I can't remember exactly how many, but 2 were white. And I've worked in intensive care for 20 years, and I have never seen an intensive care demographic like that before. And I stood next to one of my colleagues and, you know, questioned why this was, and then reached out to some of my other colleagues in London hospitals, and they were reporting the same things. And Shagan, you put out a tweet, a tweet that hit me hard, which was about, you stood with one of your nurses and you said, look around. And I don't want to misquote you, but the words were, does everyone looks like me? And that really struck a chord with me. And I think this is one of the reasons why, Zudin, we as a panel and as many people across healthcare don't want to ignore these findings. And in the light of the institutional racism that is being called out within the NHS, this is why this conversation is happening and is important. So Shagan, can I come to you for your comments on that? And we can start us through some of the lived experiences now from people.
So I remember that tweet because I remember that night shift very well. And it was in the middle of a COVID ward. Half the people were upside down, half the people were supine, they were all hypoxic. And one of the other nurses with me was black, and I looked at her and I said, they all look like us. This feels almost like a black plague. And she said, I know, I've been thinking that the whole time. And that's a very difficult place to be, because otherwise, phenotypically, and this is the thing I think that I'm hoping that the research that's coming out of Barts will pick up. Phenotypically, aside from skin color, they were identical to the white patients. They were middle-aged people who were pretty healthy with maybe 1 or 2 comorbidities. So aside from that, there was nothing else to pick. There was no, people talked about vitamin D and obesity and all sorts of stuff, but it wasn't really that. They looked exactly the same. And we know now from, I don't know if I'm hoping that people have read all the books about race science that have exposed how awful and non-existent race science actually is, but there is nothing on a DNA level to separate people with more melanin than people with not. So that has been burning, and that burned to my mind a lot. It's still been burning in my mind now. And still starting to unpick that and still going on to unpick that is actually really, really difficult.
Thank you, Shagan. Grace, I'm going to come to you next as a frontline nurse, and just for your thoughts.
So for me at the time, like I said, I was a diabetes specialist nurse trainee, and I was on a 9-month secondment. And so I had 3 to 4 years experience on the ward already as a staff nurse. And we were already anticipating the fact that some of us would have to be redeployed to the wards, but we didn't actually think it was going to happen. For me, it was quite a different experience in that I didn't really think COVID was as serious as it was in the headlines, because I wasn't on the wards. When you're doing diabetes nursing, you're doing clinics and you're doing clinic reviews. It was only until I got redeployed to the wards that I saw, okay, COVID is actually real. And even telling my friends my friends would always ask me, oh, is it really serious? Because nobody would believe it. I said, yeah, COVID-19 is definitely real. I was most worried about me being lost in transition. Would I have to stay there? Because they said they had no idea when I returned back because of how short-staffed they were. And as soon as I went there, straight away I was in charge of the ward. We had a cardiac arrest within 5 minutes. I was like, really, my mind was blown away. We were short-staffed. I was in charge with junior nurses. And I was just bearing in mind that my experience as a nurse, I had experience as a staff nurse, but I had minimal experience as a band 6 nurse in charge. So this was the first time really that I was putting this into practice. And it was literally the hardest time, I'd say, in my nursing experience. I've never forgotten it till this day. I've never seen that many patients so sick in the hospital, that many people. So it was a 22-bedded ward, and everybody from 1 to 22 was on oxygen, high flow oxygen, very, very unwell. Everybody was so uncertain about the PPE that they had to wear, because every single day we had changes from the infection control nurses. And so you'd find a lot of my staff nurses weren't happy about wearing some of the surgical masks. I was okay with it. I just wanted the ward to run smoothly as much as possible, but you tried to accommodate what people were happy with and what they felt safe with, because a lot of our staff were of the Black and Asian community. So I wouldn't want any of my staff to say, okay, I'm not working, because they would then go off sick. I was especially concerned about the fact that we were highly short-staffed. I'd find myself in charge of the whole ward, also looking after patients as well, making sure everybody's safe at the same time. And I was quite surprised at myself at the same time of my abilities. You know, when you're just put into a certain situation and you don't really expect it, what you can actually do at that time and space. Not that I want to go back, but it did make me think, wow, like, Grace, you're really capable of doing these things. And I just remember one time, one of our patients, we needed to transfer quickly to ITU, and I was just running up and down the hospital trying to get oxygen, because the hospital got to a point that they were low on oxygen, and I just thought, I've never seen this before in the trust. And it was 12-hour shifts, so 7:30 a.m. to 8 p.m, but I'd find myself leaving at 10 p.m, literally every shift that I was working, because being in charge, you'd make sure that your patients are safe, the oversee of the staff that are changing. And I think one thing that got me very teary was the fact that relatives couldn't come to see their the patients. That got to me, because once the relatives were admitted to the wards, for me in my head, it was kind of like, sorry to say, but like a death sentence in a way, because they didn't know whether they were going to come out alive or not. As far as they were concerned, they were COVID positive. And I felt like it was in my duty to make sure that, because the telephone calls were going non-stop, and I felt it was in my duty to make sure that I'd at least call them and make sure that they were informed, which was really, really hard. I remember one of the relatives, she was so pleased with a telephone call that I made at around 10 o'clock. And for me, that got to me a lot, because I just thought, if I couldn't see my mom, if my mom was admitted to hospital in COVID-19 period, I don't know what I'd feel like, and I couldn't see her. And it was just really, really sad. But I felt quite proud of myself. When I was going, I was anxious, but I was also excited and ready, because that was my background as a staff nurse.
Thank you so much for sharing your experiences, and I know so many people will relate to that, as well as your anxieties, Grace. Thank you. I'm just going to give Gavin the chance to introduce himself, and also once he tells us his role, Gavin, you're very frontline worker. You can maybe share some of your experiences as well. Thank you.
Hi, I'm Gavin. I'm an advanced critical care practitioner. My background's in intensive care nursing. And like Rachel, I've been working in intensive care for about 20 years now. My second pandemic, I wasn't planning on a second pandemic in my career. Hopefully, you would imagine it would have been a once in a career opportunity, but now we've had the benefit of getting two. I work at Harvey Hospital in East Birmingham, and we were very, very, very badly hit. I would imagine we were probably the biggest admitting intensive care unit for critical care patients across the region, although we had to transfer a great deal of our patients to our sister tertiary centre to allow us to keep admitting patients, but we were very badly hit, and over probably about a 2-month period we ventilated 88 patients between ourselves and our sister DGH on the east side of Birmingham. I remember the night for us that the surge started, we'd have a couple of COVID patients over a period of a few weeks. I was doing a night shift on a Tuesday, and that night we took 4 patients with COVID, all very sick, all very hypoxic, all with severe ARDS requiring very high FiO2s once they were ventilated. So we took 4 that night on our 11-bedded unit. We sit right next to our main surgical area in our hospital, which has 5 theatres and quite a large recovery. By the Saturday, we'd filled theatres. There's 5 areas. By the Wednesday, we'd filled our recovery. and we were up to probably around 35 patients, bearing in mind that we usually ventilate 11. We didn't have any additional staff at that point. We just coped. It was just like watching Italy on the telly, except it wasn't on the telly, it was in front of me.
And I think that's a really good point. It was kind of like 3 phases, wasn't it? There was a kind of, we know this is coming, and we didn't have any disparity data from any other countries, but we knew what the impact it was going to have, particularly on critical care. Then we had this middle phase of actually having more intensive care units and where escalation areas full. Then we had the realization that there was an ethnic background that were disproportionately affected because we could see that. Then there was realization from staff that this was real, and then there was the anxiety. So that's the kind of bit I think is important to get into next. And this is such an emotive and sensitive area. That's why I'm so grateful everyone's here. And we'll particularly struggle to find nurses to speak, because I think the emotion and the anxiety is still there as we prepare for second wave, or we're in second wave in some parts of the country. So it's kind of like, how does anyone feel comfortable about how that affected them, and like to help understanding and how we can help prepare our staff in the future, and not just for this second wave pandemic, but also for the future, and how we address that and recognize that, not just as clinicians but as managers. I don't know if anyone wants to come in on that, or Zudin, if I can come back to you, and then if anyone else wants to come in.
So I'm going to put it out there that by using the BAME term, we are moving away from supporting the really vulnerable members of our staff at the moment. So in my hospital in East London, to think that I myself, a 40-year-old gentleman of unknown ethnic origin, but within the BME, has the same risk for coronavirus death as our black porters, the people working behind who serve all the food, the people who work for Sodexo. It's ludicrous. Clearly, they have a much higher risk. Okay, and they are given the same amount of protection as I am, which is nothing, right? So there is a discussion. We have to go through our risk factors, and you have this. But actually, what we don't do is turn around and say, and I think I have to be fair to people like Polly, our clinical psychologists, who are fighting this boat, saying we have to give differential support to our black nurses, to our black porters, all these people who are watching, not just people like Shagan said who look like him die, but people they know die, and that in these small communities. And that's really, really important. So getting that across to people is really, really important. That's not happening. And one of the things I blame for that is the BAME term, right? Because you then say, well, oh, you've educated Zudin, right? So tick in the brief, that's one BAME person, educated and safe. That is not the same as educating the 2 cleaners and protecting our 2 cleaners, vaccinating our 2 cleaners when it comes along, testing our 2 cleaners when we can test people. Those are not the same things, but in an Excel spreadsheet of BAME, that is the same thing. And that is why I hate the term. And so what are we doing? I don't know what we are doing, because what we're doing is muddled, because we're trying to address a BAME problem as opposed to what our actual staff need.
So I think that's a great, one of the reactions or actions from NHS England was the risk assessment tool. So, but there's been such inconsistency about how that was adopted. Now, wouldn't it have been great if someone could have co-produced a relevant risk assessment tool nationally that we could have adopted? But no, there was just a guidance to say this is what should happen. But like you said, Zudin, what that took away is the individual part of it, because it's become a blank tick box exercise in a lot of cases. And I do think some of the better organisations, maybe if that's the right term to use, are seeking out those staff, like you said, people want to know who their staff are who are most vulnerable and at risk, because you could also be from a higher, risk ethnic background, but also have another comorbidity. So there's more than one disparity here, and I think there's lots we don't know. Sabia, I can see you quite active. Do you want to come in here?
Yeah, I was thinking that, I mean, it depends on different organisations and how people have used the risk assessment, but in our area in Stoke, we didn't see the kind of our patient population. The vast majority that we were seeing in terms of being at risk was white British males. So, I mean, I could count on one hand how many people that fit the BAME category. We did have some, and there were some issues in terms of meeting their cultural and language needs. But the vast majority is that the person that seemed most at risk of COVID were our white male colleagues. And when we did the risk assessment, and I did mine as well, I think the BAME staff probably got their risk assessment done before anybody that's got underlying health conditions that is not, from those ethnic minority groups. I found the conversations helpful. All of a sudden at work, we were looking around at each other and going, oh, you're at risk. And, we used humor to, and then we'd balance it out and go, well, actually, you're a white male, so you're scoring higher than I am, slightly, on, higher on the weight scale. But we started all of a sudden talking about race and culture, and we were unpicking the why. So why was it that in Stoke-on-Trent we were not seeing, what people were seeing in London? We didn't. So we were sort of thinking from an academic point of view, what is this? Is it the health inequalities? Is it that the patients on those units are representative of their communities in that area? Is it genetic? Is it to do with a stronger strain? So those conversations started early on in March.
Yeah, that is a really great point, and just brings us on to the same strand. But I'm going to come to Warren, and Warren raised a great point offline, and it was about how did you feel about working in an ITU that you then knew you were potentially at risk, and then that potential risk was confirmed, and how was this talked about in the workplace? So what are your experiences from that perspective?
I think initially it didn't really cross my mind because I was on annual leave just before I returned to the surgical wards and ICU. I was just going back in to do the job that I've done before, manage surgical wards and help out on the intensive care unit on ITU when needed to provide respiratory physio care for people that need it. And it wasn't until I think from a physiotherapy point of view, we were very fortunate that we were getting regular updates from our governing body about types of PPE to use. There was a risk performer on what type of PPE to use for the different types of patients. And because that was quite accessible over the internet via Twitter, I could have that at hand whilst I'm at work to decide what type of PPE I need. And being in ITU, I found that was probably in the most safest environment for PPE use compared to being on a respiratory ward where they might just be using surgical mask or an apron and gloves. And it wasn't until probably say 2 to 3 weeks in that I started to think, actually, this is becoming quite stressful. Although I'm not in the PPE all day long compared to there are intensive care nurses who are managing the job of an unwell patient, supporting extra staff that have come to the unit to help out, and then doing their day-to-day in all PPE for 12 hours. It started to, I think it really hit me initially in sort of the first week when I was like, somebody mentioned before, seeing a patient who can't be with their family. This patient wasn't really a COVID patient. They had a spinal injury. They were pretty much a tetraplegic from say C6 to C7 down, and they had no way of sort of communicating with their family because they didn't really have the use of their arms. They weren't allowed to see their family because of the restrictions that were in place in our trust at present, like similar throughout the rest of the country. And that was just, for me, that was probably the most upsetting point, because I was just like, this poor gentleman has had such a traumatic injury, probably won't be able to see his family for months on end. He's literally at the beginning stage of his injury, and then he's stuck looking at the ceiling for the next sort of 4 weeks or so. And that for me was the moment where I was like, actually, I'm already quite stressed because of the mental fatigue that I'm carrying and the mental burden that I'm carrying just doing my job. As I then went through the job, you sort of just push things to the back of your mind because you want to get on with what's in front of you. The nature of the job, I can cope with that, but it's when people say, oh, it's been great managing, we've had lots of time, clinics have been shut. And I think sometimes people actually forget that some of us, we haven't had a rest. And I think that's the part for me where I was like, actually, this is becoming quite stressful, because some people are enjoying the freedom of clinics shutting down because of the nature of the COVID pandemic. But actually, there are other people that have gone from like a different job straight to redeployment, straight into a pandemic in PPE for hours on end, carrying the mental burden. You see in people in your community that that are potentially managing with COVID symptoms. And then at the end of the day, coming home and you hear people on the news or in the community saying, well, it's not a real thing though, is it? So, a 50-year-old man that gets it and goes into hospital, they'll be fine. And you're like, no, they won't. And I don't understand why you won't listen to me if I've been on the front line. But what can you say to people?
I hear you, and I think that's a valid point for people that are listening. Kieran, I'm coming down to you now. Thanks.
So I have a couple of points. So kind of similar to what Warren said, we were struggling a lot with how the patients were managing not being able to see families and things. And luckily where we were, we had access to iPads on the ward, so on the unit, sorry. So we were providing kind of video calls to patients' families, which I felt provided a lot of kind of relief for us as much as for the families and the patients themselves. We just thought that was really good. In terms of how we coped as a trust, I think they did very well in terms of, as soon as the BAME, or whatever we're going to call it, paper came out, our trust put out the risk factors early and told us, if you are an increased risk, if you are amber, then you need to set out and set up a sort of help group within like the BAME community in the hospital, where we contact each other and talk about how we feel. For me personally, I didn't necessarily think that I was at more risk, even obviously I am of a minority ethnic background, but my initial thought process was, it is probably because people are in low income areas, in areas where they're not able to kind of spread out like we are in Cambridge. So we don't have many cases, we're spread out, we've got a lot of money, people can stay home, they're not still having to go to work with no PPE. So for me, I wasn't worried about getting COVID or getting it worse than anyone else until a consultant said, people thinking that this is a racist bug are wrong, and that it's not targeting people, it's just that Black people are more susceptible to it, or Black and ethnic minorities. And that's when I was a bit like, oh, okay, our consultant saying this could actually affect me. And at that point I was like, okay, yeah, this is getting real for me as a 24-year-old young male. I thought I was okay, but now I'm a bit more worried about it. But I think our trust as a whole did really well, and supported its patients and staff.
I think that's so powerful. Zudin, I'll come to you. I want to make an admission here and a disclosure, because I was one of those managers that sent like that kind of email, and I had somebody come back to me who was so upset with my email that I thought was from a great place that I'd reached out to a population of my staff that were identified at more risk, but they themselves had never put themselves in that category of being at risk. And I hadn't been mindful of the fact that I had potentially drawn the fact they were at risk in what was an email. And that was insensitive of me. And I've learned from that there was follow-up abilities to have the conversations, but how you communicate such emotive and, you know, a conversation area that can draw up really bad trauma for people, that I'm very mindful of that. So I want to make that admission that I'd done that and I learned from that and acknowledged and apologised. Zudin.
So Kieran, I guess my question is now, like, we're just kicking into the second wave. You know, it's early days. So now, do you think that you're at risk? Do you think you're more at risk than Rachel, or you're at Cambridge, right? So any one of you've got some fabulous consultants on the John Farnham unit.
Yeah.
So Johnny Martin, there you go. Do you think, you know, are you more at risk than he is? He's my age. He's very young, clearly, in that case. What do you think?
It's a difficult one. I think if I use my kind of common sense, it would make sense that I wouldn't be more risk. But from what the research is saying, it's something that you have to take into account. It wouldn't ever stop me doing my job, so I wouldn't ever not go into the unit and put other people at risk because I consider myself to be at more risk. But I think it's a really interesting question, and if I was a similar age, if I was getting kind of towards like maybe 50s, 60s, where they were saying that we were then at more risk, I think I might be thinking differently. But at the moment, even though I am at more risk than white people my age, I'm still not at that higher risk from the papers. But as a whole, I don't think it makes sense. As Sagan was saying, like we don't have different DNA. I shouldn't be that different to someone else who is white and my age.
Thank you. Gabby, can I come into you next? Thanks for your thoughts.
Sure. I echo most people's experience that's been discussed earlier. So I'm originally from Malaysia, and my background, same like Zudin, very much mixed. So my father is Malay, pure Malay, but my mom is from Chinese and Arab descendant, as well as she's actually from Indonesia. So I come from a very mixed background. So when it all, my very experienced dietitian, I'm a senior dietitian. To perform as a clinician, I should be leading my team to support the ITU dietitian. And my concern back then was like, okay, how can we support the junior staff to support us to cover all the cases on ITU? Because we started with like, same like others, only few numbers, and then suddenly within a week, our ITU was full 12, and then week after was 24, and it just keep on increasing. And then within the first week when I started providing cover to ITU, one of the psychiatrists, Reg, came up to me because we work closely, and she said, Gabby, you know, it is a tough time. If you need any help, any support, please do come and see me and speak to me personally. And I said, oh, I'll be fine. I wasn't really thinking about the whole thing. It's only until a few weeks later, because obviously, because I was covering ITU, so I was separating myself from everyone. I just come home, go to my room, shower, just like isolate myself because I don't want to risk anyone. It's only after 3-4 weeks that it really hit myself. And I think that's also when one of the junior dietitians broke down and cried. And I was thinking like, what happened? I've totally forgotten, like, this is a new experience for them. We never really cover ITU. And also when a person actually came up to me and said, Gabby, are you not worried because you're from ethnic minority background and you have asthma, you're not worried about yourself? And I was thinking like, I never really thought about that. Like, I never really thought that I'm someone who's at high risk. Yeah, so it was interesting that ethnicity was not my priority to think that I was at risk, and also still being close to people in Malaysia. If I think about it, okay, the whole country should be, you know, ethnic minority, and they have the lowest number compared to the UK. So yeah, it's an interesting experience. But I think it's also very individualistic, because it depends on what is your coping mechanism is, what is your priority, how do you see yourself, how do you see yourself in that picture, and how would you carry yourself. And I think in that particular moment, I was thinking more about my patients and my colleagues, how to support each other, how to stay positive, well-being, instead of worrying about my own medical condition, my own ethnicity, and how would I cope with it. And same like others, when the NHS assessment risk tool came out, and I have to fill one to kind of like whether I be qualified to be working, you know, with patient, inpatient, face-to-face. And that actually make me think like, oh, I don't want to take myself as ethnic minority because that will give me extra score. And I was thinking, age category, I'm not scoring high, you know, yes, I have asthma, but it's not that I've been admitted with, you know, chronic condition. Yes, I'm using my inhaler. I almost feel like, should I lie about my ethnicity? So yeah, it's a very mixed feeling when it comes to that. And I was quite disappointed because I was scored medium risk. And I was thinking about, oh no, then I might not be able to contribute with the second wave because I'm more experienced now. I know what to deal with it. And I know how to support my colleague better because I've gone through the first wave. Yeah, a bit of disappointment, you know, personally when it comes to the risk tool. But I don't see myself, like Kieran, I don't see myself as someone with a high risk just because of my ethnic background. I think those people who are from white ethnic background, but they have more comorbidities, you know, higher BMI, those kind of condition are pretty much high risk compared to myself.
And I think that's the thing, there's lots of evidence out there for a number of years now looking at health inequalities and the correlation between race and ethnicity and lots of other demographic factors. But it was because the correlation was made during not just a global pandemic, but within a UK population and cohort. And I think that is the most striking thing here. I think that is part of the discussion. Leanne, can I come into you next? And then Shagan, I'm going to come down to you just to warn you. So Leanne.
Yeah, no, I think my experience sort of, you know, tallies up with, you know, what we were talking about. You know, even though I'm from a ethnic background, I didn't necessarily see myself as high risk because I'm, you know, of the younger age, I don't have any comorbidities, but I was very aware of passing it on to my parents and my elderly relatives, because that was who I was seeing in the ITU beds was, you know, people that looked like my mum and my dad. And, you know, I was really quite aware of that. So I think like a lot of people, I didn't, you know, see my parents for 6 months, and, you know, that was hard, but that was a, you know, decision that I took because I thought, you know, they are high risk, they are older, they have comorbidities. I didn't want to put them at risk just by being in proximity to them. But yeah, no, I never actually really saw myself personally being at risk, and that might be quite naive of me. But you know, I definitely was more concerned about other people than sort of, you know, my own health and how it might impact me.
Yeah, completely. That is something that has been reported to me from my staff as well. So I completely can, you know, relate to that, and I think appreciate that. And I think that's a sign of people's integrity as well. And as a, you know, as a white manager, that's something that I definitely paid respect to and took on board and recognised. So Shagan, can I come to you, please?
So I'm going to come back to something that Zudin said, actually, and there's two aspects to it. So I completely agree with what he said, that the fact that someone like me who works in intensive care, as an experienced intensive care and anesthetic registrar who knows how to don and doff PPE and gets FFP3 masks and the full shebang, is considered the same risk as a porter who basically works at the front desk, sees loads of people coming in and out, people probably coughing on him every day, and he's wearing a surgical mask and a plastic apron. I think that's completely insane. And the second thing that nobody's asking, or the question that I really want to ask, is why is everybody else who looks like me in a hospital a porter, a cleaner, or somebody who's serving dinner? Why are people not asking those questions? That was what really got to me. And those are the questions that I would like to see people really sit down and talk about. Why is it that when I walk down the corridors, still today in my own hospital that I've worked at for 15 months, people think I'm a nurse or a porter? Why is that?
Well, I think it's because of stereotypes and institutional racism and lack of opportunities and so many things, Shagan. And I think that is such an incredibly powerful and valid point. And as the kind of white person in this group, I think that would be my own reflection of why that is. And what we need to do is absolutely analyse that in greater detail and provide opportunities in an equal playing field and role models. And that's part of what this podcast is about. All of you guys as really successful people and having this conversation. I think, what was the first point you made about PPE? Now, just because I've done a podcast on it, there is actually data now, a thorax publication, to show that the areas where just surgical masks were used during COVID, there was a higher incident of healthcare infection and also silent carriers. So I think that's a really powerful point that needs further discussion. Should more high-risk, vulnerable healthcare workers be given higher level of PPE because they are more at risk? And I think the answer has to be yes. But I think that's probably for a wider point outside of this group. Can I come to anyone else? I'm conscious of time now, so if anyone wants to just go ad-lib with the conversation or bring anything in, that would be great.
Can I just touch on that point you mentioned about PPE? I asked my deputy CEO, what would we do in the incidents that people from an ethnic background don't want to go back into their frontline work that they managed in the redeployment time because of the risk of not having enough PPE? And our trust is 20% BAME workforce, and sometimes I think it can be a bit frightening, because you think, well, if there isn't enough PPE, what are we going to do if there is a big second wave like there was before? What do you do if if I think it's 10 to 15% of our medical team are from a BAME, or sorry to use the term, BAME background. If there's not enough PPE to go around, then how do we support everybody in that role and those positions? And, what's the burden going to be for people? I think that's my only sort of worry and fear about going back into a frontline role. I'm not like Kieran and Gabby said, I'm not fearful or frightened about my race or my skin color and how it might affect me if going forward potentially becoming at risk of catching coronavirus. But it's more so, what if there's not enough PPE? And like Shagan said, it should be available for everybody, whether they're porters, clinical support workers, if they work in a restaurant. And that's probably my only fear about that.
Thank you. I completely agree. Thanks for raising that, Warren. Kieran.
I just kind of wanted to raise something that we've been kind of speaking about this whole time but haven't necessarily focused on, is that we're saying all of these patients look like me. All of us look very different, and none of us look the same, but we're all, and I know this is kind of what everyone was saying in that this BAME kind of word puts us all together and clumps us together and doesn't let us be individuals and achieve and get beyond that. But I think the fact that they're saying that all of us from such varying backgrounds and varying kind of colors and beliefs are all the same and all at risk doesn't necessarily register with me. And as kind of other people were saying, the fact that we're all tending to be pushed towards these kind of lower paying jobs and not necessarily allowed or promoted into going into these kind of medical posts like the guys are. And when you look at schools like Oxford and Cambridge and they're not accepting in people of minorities and they're not given the opportunities, I think those are the bigger conversations that need to be had beyond this.
Great, thank you, Kieran. Grace.
I just wanted to touch on the point I think Shagan mentioned about why there's correct me if I'm wrong, why does every nurse or porter is from a Black African descent? I wanted to touch on that. I think a lot of it is, or mostly, to do with, it's very culturally deep rooted, I think. Personally, for myself, coming from a Ghana background and a very cultural home, my mum was a nurse herself, and she had 4 girls, and 3 out of the 4 girls are nurses. And I think in the African culture, particularly in Ghana, nursing and anything in the health profession, nursing or doctors, is seen as such a, it's dealt with high regard, because it's a caring job. You're looking after people's lives. I think lives are taken into such high regard. And also I think it merges with the fact that Ghana itself is a religious country, I think Christian and Muslim. And I think within the religious concepts, a lot of it is looking after people and caring for people. So I think a lot of the reasons why Black Africans tend to be more like healthcare professionals, can't comment, I don't know for the about the porter side of things, but I do know a lot of it is culturally deep rooted. I know I was heavily influenced myself to become a nurse simply because I saw my mum practicing as a nurse, and the rest of my sisters were influenced that way. So yeah.
Thank you, Grace. Zudin.
Grace, I don't disagree with you for 1 second, but just to be clear that every single report of medical schools and colleges when it comes to doctors is very clear about the racism that exists. And if you look at the pinnacle where that racism is, it is with Black people, as in they are the most disadvantaged in through medical school and in through NHS posts and into leadership roles. So I'm not just talking about, and the problem with that is that you then don't have the role model. So Shagan gets endless text messages from me saying, hey, can you talk to this guy? And I can't think of who else sends you, or every young Black doctor knows Shagan, okay? Because they all say, I can't do this. I don't know anyone who looks like me. I go, I know one guy. Actually, I know 2, Hakeem Yusuf in Leicester. He gets phone calls too, okay? But this is the problem, I think. So just, Grace, as you were the role modeled into it, in this country, there isn't the role model for the next generation. And that is that's what Kieran pointed out just now as well, right? And that is the one thing we can take away from this is that you have to step up and role model people if you're going to talk about this stuff.
Absolutely, and we have a real problem in the allied health professionals with our ethnic diversity, and that has only come to light and been recognised during this pandemic and the Black Lives Matter movement, which is shameful. So this happens across healthcare. In psychology as well, I think it's fair to say. Now I have Shagan, and I think Gavin, you had your hand up as well. So Shagan, can we come to you?
I was just going to say that everyone in this panel has the right to feel very proud of themselves, because this is a panel full of role models. All of you have been successful in your fields and have been successful as non-white people, and you have no idea the impact that you'll have when you walk past other non-white people and they see somebody who looks like them caring for them. So please take that with you and remember that every day. You guys are awesome.
Oh, thank you. I felt like you should have saved that till the very end bit. You can maybe repeat it. Gavin.
I was just going to reinforce some of the things that Zudin was saying. I certainly remember a couple of years ago going to an RCA exec meeting with the trust board, and it was so stark walking into that room. It really did feel like a firing squad. There were 2 brown people in that room, me and a consultant who were there regarding the case. The entire board was white, and it certainly did not feel like you were going in front of a jury of your peers. And I hadn't really thought about it until that point, but it was so stark when I walked in that room. I just felt like saying, where did all the brown people go? I work in a trust where probably 40% of the people that I work with are Black and brown. And walking into that room, you'd think I'd walked into a boardroom of some big company in London or something, not the hospital that I work in. It was so stark. And I just had some thoughts around what people were saying about the grading criteria for the risk assessments. And I certainly remember when I filled out my second or my third, or God knows how many I had put before me in that time. But the last one, I think, was probably the NHS one. And like probably many of you that are my age, got graded in the amber zone, intermediate. And I did think of changing my ethnicity on it, or even refusing to do it, because I was just so frightened by the fact that I might be stopped from doing my job. As hard and the tears I've shed doing this job, particularly in the first couple of months, as hard as it was, the prospect of someone saying, "Oh no, you're BAME, you can't contribute to this, you can go and sit in an office somewhere," I really found that really disturbing. And like possibly some of you, I felt like actually refusing to do it. I understand the tick box reasoning behind it, but I found it really, really difficult for someone else to say what my risk is and potentially decide for me what my role would be based on that risk, rather than being able to make that decision myself.
Yeah, but if I might interrupt, what you're saying is you'd object other people defining you.
Yes, I mean the whole BAME thing.
Just thinking about what we tell our children and what we tell our girls is exactly the same thing.
Yeah,
you define yourself; other people don't define you.
I had to look up BAME about 5 months ago. I had no idea what it bloody meant. I've never. I'm mixed race. At the very most, I'd describe myself as brown. BAME? What's BAME? Got no idea what BAME is. Never considered what BAME is, or that I might be in it, or people in my family might be BAME. I'd never heard of it. I found it a really bizarre concept.
You know, and I think this is I know you missed the very beginning, but we did talk about terminology, and I think that is a whole podcast in itself. But I think, Zudin, that point you've just made and with Gavin is really powerful and definitely thought-provoking from my perspective. And I don't want to have the last word, so I just want to give the opportunity to go around the group, and if there's any final comments or things you want to say before we close the podcast, please do. Now, just so you know, the Twitter handles and people can be contacted through me will be available on the YouTube channel and Podbean if you're listening to the audio file. So please reach out to any of these inspirational role models that you're sitting watching, because I agree with everything Shagan's just said. They are absolutely fantastic, as you've heard. So Gabby, any final thoughts or comments?
Oops, sorry. I think I echoed everybody's comments about this whole situation. I think for me personally, definitely, I don't want to be separated from the whole equation, and I feel if I can contribute, why not? Why do I have to be separated just because I'm from a different ethnicity background? And I would like to be seen as what I'm capable of doing rather than what's my background.
Thank you, Gabby. Leanne?
Yeah, I just want to say it's actually really nice having this conversation with people, because I think it's been very difficult to try and even initiate this conversation, because I think so many people are, scared of offending, or, try to skirt around this issue without sort of directing it head on. So it's been really nice to sort of, have this discussion and talk about it quite openly amongst other people.
Thank you, Leanne. Gavin?
There's a lot to change. My unit is starting to see another surge, and just as before, I've got a whole unit lined up of black and brown men. In some respects, I think it's probably worse than last time, because I think the people that can isolate and protect themselves, work from home, have tech-based jobs are doing that. And I think that with the last set of ITNAR data I saw a few days ago, it actually looks like the disparities got even bigger since March. I don't know what the cure for that is, but it almost seems that as this goes on, the issues around Black Lives Matter and socioeconomic disparities in this country, that they're going to get highlighted to a greater degree.
Thank you, Gavin. Kieran.
Yeah, so I just wanted to thank you first for getting a group of people together and trying to raise a profile of people who are kind of pushed down by society and letting us have a voice. I think this is something that needs to be bigger than this podcast. It needs to be bigger than us individually, and it needs to go to the top. And I think that the BAME kind of movement, or whatever you want to call it, is a way for people to be racist without being racist. It can put all of the people together and just minimize all of us together rather than picking individual races. It's a great idea, and giving us the opportunity to work together, I can see where they're trying to go with it. But yeah, I think that's something we need to work on, and it needs to come from the top down. And as everyone's been saying, get us some role models, give us opportunities, and you'll see what we can do.
Completely agree, Kieran. Thank you so much. Shagan, come to you.
Just thanks for the opportunity to be here to chat. And my plea to anyone who's listening is, please, please, please don't be swayed by the idea that this is genetics. There is much more to it than that. Please look deeper, please pay attention, and please carry on this conversation with yourselves and with if you're a person of color, with other people of color, and with white people, and let everyone just have this conversation, and let's figure out a way forward together.
Thank you. Warren.
Oh, I just wanted to say thanks for the experience and opportunity to chat to everybody in the group. It's been great listening to everybody's stories. In terms of being a role model, I would just like to say, to be your own role model, be the person that you want to be for future generations. Lead your own opportunities, push boundaries, and always try and ask uncomfortable questions without fear that your opinion will be disregarded. And you can, and you have the ability to do wonders no matter what you want to do.
Thank you, Warren. And I know you were so focused on getting the patient point across as well in this, so I want to thank you for that as well. Grace, coming to you.
Just to say thank you for the opportunity, and I think for me, biggest highlight is would like to see more done for the frontliners, because with or without COVID, the frontliners remain the frontliners. I think COVID literally just added to it. The challenges in the NHS continue. I'm quite disheartened to see that the recognition only existed with COVID-19. What frontliners do on a day-to-day basis, 365 days in a year, is absolutely amazing. And I would like to see more done for them, rather than just a moment. But yeah.
Thank you, Grace. Sabia.
Meeting. Yes, like everybody else, thank you for the opportunity, for the conversation. It's been really deep and meaningful. I think I would not have been anywhere else. I think that being there at the front line, helping staff, helping patients, I wouldn't have wanted to be anywhere else, with risk or without risk. And I think that one thing, I think like Gavin, going into a meeting with quite senior leaders who are, majority white, discussing how they were going to open up leadership opportunities for people from a ethnic minority group, and being the only Muslim Asian minority person in the room, I felt about this small. And I think I left that meeting thinking, I'll open my own doors, I'll knock on those doors, I'll find the doors, and I will find opportunities for myself, and embrace that empowerment and opportunity, because I think that the opportunities are out there, but we don't have to remain small, and we can be amazing if we want to be.
Absolutely. And Zudin, what a person to finish on, because just a massive personal thanks, because without you this podcast definitely wouldn't have happened. So thank you so much. And the final words from yourself.
So I have 3 things to say. If someone comes at you with some genetics, I'm happy to talk through the statistics. And I've had to put my phone down many, many times, but the stupid JAMA publications, which are underpowered, trying to claim that there's something about being black. And and genetics. It was terrible, right? There are a whole bunch of terrible genetic papers out there, which are being driven by all sorts of people. So I'm happy to talk to the statistics to show you how crap these things are. I use my adjectives appropriately. The second thing to say is that, Leanne, you said it's great to have this chat. When we started doing this work very early on, I know my team really, really well, and it was just they used me as an opportunity to show people that we can talk about this in an objective fashion. So I think we're about 60%, 70% white, my consultant team, but you will now see them stopping the porters in the corridors, talking to nurses, talking about their health, okay, because they're no longer concerned about walking up to a black guy and saying, hey, you're black, have you thought about this? What are you doing here? And so on. I've seen consultants call people into their offices to have a chat about their personal health and talking about people's families, because you've empowered people who are good, like Rachel, to talk about race. Okay, so it's really important. What you can do is say to people, it's okay, I don't look like you, I don't want to look like you. I'm happy with, so we can talk about our racial differences happily. And that's an empowerment thing that we can offer people. And that way we can help other people. And the last thing to say is that everybody has lost their kindness. Everyone's tired in going into the second wave in winter. And all those porters, all those cleaners, all those people on 0-hour contracts, they're working because they don't get to work from home. They don't have broadband, Zoom, fiber, and all these things. They have to go into work to work, okay? So I think what it does behoove us is to point out that these people need kindness, okay? And that's something we can do if we're happy and confident to talk about your own color and your own race and ethnicity, that you can say, it's not about me being kind, it's about pointing out that everyone else can be kind too and should be kind. That's all I have to say.
And what an inspirational comment to finish on. So thank you so much, everyone. Really appreciate your time, giving your evening up for free. I'm very aware of that and I'm very grateful. Thank you so much.